Greetings and welcome to this module on Antibiotic Series. Here we discuss about Rifampicin, a unique niche drug that has a lot of potential uses when used appropriately, when to use, when not to use. We'll discuss about in this video in detail. The only video you need to watch about for Rifampicin. If you are new to this channel, do subscribe. This is Medicine Beyond Harrison's. Let's get started. So the rifampicin is actually a big picture. It's a very potent antibacterial drug which has a unique biofilm penetration. The only thing that you need to take home from this whole PowerPoint presentation is that it has a very good biofilm penetration. That's why it is used in most of the infections and use cases that we'll discuss in the upcoming slides. So it has an excellent intracellular penetration. That is also the most commonly used mechanism that is exploited for treating tuberculosis, and it becomes the cornerstone of tuberculosis therapy. So the resistance emerges rapidly if used alone. There is massive blood-brain interaction burden. That is also the major risk problem of this drug, and primarily used as an adjunctive agent, not as a monotherapy. Never used as a monotherapy, except in few specific cases of tuberculosis prophylaxis. Otherwise, you should never use this as monotherapy. So mechanism is, as we all know, it is a DNA-dependent RNA polymerase inhibitor. So it blocks the RNA synthesis, and it is a bactericidal drug. So critical warning is that trap killing leads to low barrier to resistance. These develop resistance so rapidly. So single step mutations occurs easily for the bacteria, so that it become resistant to this rifampicin. So it is never used alone, except in some specific TB prophylaxis. So rifampicin is very hard to use. Why? Because it interacts with almost every other drug. So it has auto-induction capacity that it speeds up its own metabolism. It has increased hepatotoxicity. It has a significant potential to cause hepatotoxicity with a derangement of liver enzymes of 3 to 5 times apparent normal, when you should stop the rifampicin. Resistance risk misuse compromises TB therapy and options. So never go for rifampicin as a monotherapy or for a first line drug. Only based on the guidelines, if appropriate, go for rifampicin. So contraindications often relative but decisive due to interactions with antiviral drugs, especially HIV and HCV drugs, immunosuppressants, post-transplant patient, critical cardiac and neuro drugs. All these drugs interact with rifampicin, so hence, try to avoid rifampicin in all these cases. So severe liver disease, hepatic clearance issues, and active hepatotoxicity, it is organ driven. So don't go for rifampicin. It's a nightmare. Interaction of rifampicin, it's a big ordeal and nightmare to handle. Rifampicin ramps up the liver's disposal receptor system completely. Almost induces all the cytochrome enzymes along with PGP. So all these will cause marked reduction in serum levels of all the other drugs. Cytochrome P3A4, cytochrome 1A2, cytochrome 2C9, 2C19, everything is induced. So it actually decreases the levels of antiretrovirals, calcineurin inhibitors, warfarin. So never use warfarin along with rifampicin, and also dual oral anticoagulant drugs are also increasingly metabolized, so it leads to increased stroke risk. It also lowers the effects of anticonvulsant drug. There is more seizure risk, steroids they lead to periodic therapy, and OCPs which lead to pregnancy risk. So always check for interactions before prescribing rifampicin. It is a must. You must remember when prescribing rifampicin to a patient. Side effects are common, such as urine color discolored to orange or red. Whether it be urine, sweats, tears, or even contact lenses can be stained in orangish color. There will be again nausea, vomiting, abdominal pain, diarrhea, and flatulence. These are also very common side effects. Serious side effects are hepatotoxicity, hepatitis, often hyperbilirubinemia, monitor LFTs often first in the 3 days, next after 1 week, then later every second week or third week. So hypersensitivity is rare, but is very serious. Sometimes can lead to Steven Johnson syndrome, toxic epidermal necrosis, and Rett syndrome. CNS can rarely cause acute psychosis and confusion also. For hematologic, so there will be hemolytic anemia, leukopenia, thrombocytopenia, and thrombotic microangiopathy. All these can occur with uh, this rifampicin. Renal, it can lead to interstitial nephritis and acute renal failure. So almost all kidney, liver, hematological problems, gastrointestinal problems, central nervous system problems, and hypersensitivity problems. Everything occurs with rifampicin. So it is always engaged with the rules of engagement. So generally not as helpful for any ICU infections, except for a few cases in CNS meningitis or tuberculosis. Avoid at any cost if possible due to a lot of interaction burden. So remember one thing: if you are giving rifampicin to that patient, the drug chart should not have more than 5 to 6 medicines. If in case of tuberculosis therapy, then go no more than 7 to 8 medicines to prevent all the drug interactions. Never start rifampicin casually. Rifampicin in endocarditis, delay the initiation of rifampicin in endocarditis, especially in prosthetic valve endocarditis. Start later 3 to 5 days after the effective bactericidal therapy to prevent resistance. So always involve the infectious disease consultant when starting rifampicin for endocarditis. So spectrum of activity, it has a wide spectrum of activity, but not active against Enterobacteriaceae organisms. It is active against gram-negative Acinetobacter, Legionella, and Haemophilus. Whereas for gram-positive, it has few niche activities against Staphylococcus aureus, including MRSA, Coagulous negative staph, and Streptococcus pneumonia, and group A Streptococcus. Again, mycobacteria, it is a core indication of rifampicin nowadays. Rifampicin is used only for two things nowadays. It is one adjunctive therapy, added to prevent relapse, and for biofilm sterilization. It has like excellent potential to penetrate into the slime layers of the biofilm. So it is never used alone except for TB prophylaxis. So indications for prosthetic and hardware. Prosthetic valve endocarditis it is used. Prosthetic joint infections and pacemaker devices because of the ability to penetrate the biofilm, which makes it most valuable in these regards. So for pacemaker devices and device infections, prosthetic joint infections, prosthetic valve endocarditis, rifampicin becomes the most useful drug. For CNS infections, penicillin resistant Streptococcus pneumonia, you can go for rifampicin. Again, hardware and associated ventriculitis in case of VP shunt and leading to ventriculitis, you can go for rifampicin. Used with other agents and not alone. So other indications, regional adjunct in severe cases. Tuberculosis, the primary indication, water for therapy, rifampicin, isoniazid, pyrazinamide, and ethambutol therapy. Anaplasmosis can also, second line can be used, rifampicin can be used. Dosing is not one dose fits all. There is no standard dosing for rifampicin. It is based on the type of infection that you are targeting. Meningitis, it is 600 mg Q 12 hourly, that is daily dosing. And prosthetic valve endocarditis is 300 milligram Q 8 hourly, whereas tuberculosis is 600 milligram once daily. Anaplasmosis 300 milligram twice daily. These are the common dosing guidelines for rifampicin. It's either 300 or 600. That's what it is. So pharmacology, it is a high molecular weight 822 gram per mole molecule with a highly lipophilic component and oral bioavailability almost 95%. So hence given orally. So food effect, it is decreased by food intake and absorption is decreased by almost 30%. Hence prefer dosing on an empty stomach when possible. So always give RC flags or RC with rifampicin combination with tuberculosis therapy. Arsenic should be given early in the morning before food. Distribution, this protein bound, 80% is protein bound. Then it has excellent penetration to bone joints, meninges, intracellular compartments, abscesses, and biofilms. It is almost superior to inflammation in case of a biofilm present, if a biofilm is present. Metabolism, de-acetylation, there is a active metabolite. There is auto-induction of metabolism. There is no non-linear pharmacokinetics at high doses. So basically, hepatic metabolism, excretion is through biliary system. Enterohepatic recirculation is present. Almost 15% is excreted unchanged in the urine. There's no renal adjustment required in case of usage of rifampicin. So half-life is very low, only 2 to 3 hours, decreased with repeated dosing due to auto-induction. Hepatic function is a key determinant for pharmacokinetics. So it's not useful for undifferentiated ICU sepsis. I always keep this in mind. It only adds toxicity and interaction without benefit in most cases. It is reserved for clear guideline supported indications only. So always ask this question: what unique benefit does a rifampicin add in this case? And then if it really adds some benefit, then go for the drug. Otherwise, don't go for rifampicin. Common mistake using rifampicin as a monotherapy is the blunder. Starting too early in endocarditis again a big major blunder. Starting it even for prosthetic endocarditis, prosthetic device related endocarditis. Don't go for uh, rifampicin early. After 3 to 5 days of appropriate bactericidal therapy, you can go for. Ignoring drug interaction is one another major blunder. The patient may even succumb to multi-organ dysfunction. So using for routine bacteremia is always discouraged. Forgetting hepatic monitoring is again discouraged. You should do hepatic monitoring initially at 3 days, then after 1 week, then after 3 weeks, then whenever possible at 3 weeks interval. So one last slate take home points that you need to take away from this rifampicin is that it penetrates biofilm excellently with even for prosthetic infection it is preferred, very preferred. It is for tuberculosis almost the first line therapy. It is selected CNS infections like Streptococcus pneumonia, meningitis. It's a very good drug. And for Legionella, it is used as an adjunct. So avoid for empiric ICU therapy, avoid in unclear indication and critical interacting medicines. Always check the drug chart before adding rifampicin. In case of advanced liver disease, never go for rifampicin. So hope you learned a lot about rifampicin and hope you confidently use rifampicin drug in your clinical practice every day. If you like this, like this video, do like and subscribe. This is Medicine Beyond Harrison's. Thank you for watching.